യെസ്, വിസിബിൾ ആണ്, ഓഡിബിൾ ആണ്.
ഓക്കെ, ശരി. 1 second. ഇതിന്റെ മുകളിൽ ഒരു പാനൽ കിടക്കുന്നുണ്ട്, എനിക്കൊന്ന് അഡ്ജസ്റ്റ് ചെയ്യാൻ പറ്റുന്നില്ല. 1 സെക്കൻഡ്.
ആ
Okay. So today we are going to discuss something about poisoning in children, common poisons, and what to do for uh, poisoning in the common poisoning in children. Okay, as Praveen said, poisoning is actually a very common emergency in the pediatric practice. Whenever we are sitting in the casualty or when the patients are admitted in the wards also, the one of the common indications for the patients being brought to our side is actually poisoning. And poisoning, majority of the poisoning in children is accidental. But some cases we also do see intentional poisoning, especially suicidal poisoning can be seen in children, in the adolescents and also older children. And very rarely we do see homicidal poisoning also. That is usually seen when the families commit suicide at all. Then children are also given the same medicine. So that is what we usually see. But majority of the poisoning that we see among children is accidental only. And another problem is with the poisoning is that the history may not be very reliable in the case of children. And hence, even if the history is not there, we need to suspect poisoning when the patient comes to us with typical toxicology. And early recognition and prompt management is always critical in the successful treatment of poisoning. Okay, so what is poison? Poison is a substance which, when introduced into or absorbed by a living organism, can cause injury or death. And poisoning is a predictable dose-dependent effect that results from overdose of a potentially harmful agent. That tells us that this is dose-dependent. When the dose increases, the symptoms and severity of the poisoning increases, and it's predictable. Whenever a patient takes a particular drug at a particular dose, the patient will have these effects. That tells us that this excludes the allergic reactions and also other idiosyncratic side effects. This is something which the layman or our patients may or parents may confuse, because all the side effects of the drugs are actually not due to poisoning. Although only those effects which are due to overdose may be considered as poisoning. And why poison is so common in children? That is because of the vulnerability due to the developmental stages. Children, when compared to the adults, they are very keen and very curious, and they always want to explore the environment. And whenever they come across something, they want to explore it by putting it in the mouth and all. And whenever they see something, they want to experience what is that. So that is why we have a higher incidence of accidental poisoning in children. And the most common age group of poisoning is between the toddler age, between 2 to 4 years. Why? Because after 5 years or so, the children will be able to understand the consequences of their action. And if you tell them something that it's very harmful to take this stress or anything, putting anything in the mouth, they may obey you. But between 2 to 4 years, they do not actually understand the consequences. So they are very vulnerable for taking any drug into their mouth or any household objects or chemicals they can ingest. And along with this problem is compounded by the environmental factors like poor storage facilities. The chemicals in the home and also drugs need to be actually stored in childproof containers, and it has to be kept at a place where the children cannot access. But this is not happening in all the cases. And parental or caregiver negligence also contributes to this increased risk of poisoning. And another thing that we all need to consider is that not all poisoning are declared. In declared poisoning, the parent or caregiver will come and tell us that the child has taken a drug or chemical. There you don't have any problem with the diagnosis of the poison. We just need to act and give whatever is needed for that person. But and sometimes the poisoning may not be declared. Undeclared of poisoning where there is no history of intake of drug or poison. And the parent or caregiver, they don't give the history. Why? Because they feel that their child will not take any unnecessary drugs and all. And they will actually deny the history of intake. And sometimes they may willfully withhold information also. That we see when the parent is not the caregiver. Usually when the child is trusted with somebody else like uncles, aunts, or grandparents or neighbors and all. If the child took something, when they were taking care of the child, they are very reluctant to give the information. So always suspect poisoning when the patient's symptoms are not explainable by the history. Okay, that is something that we need to do. Especially when the patient is having unexplained CNS symptoms, patient is having drowsiness, coma, ataxia, abnormal movements, always suspect poisoning. Because if the symptoms can be explained by the history, that means child had some fever, some irritability, then gradually progressing altered sensorium seizure, that could be due to some infection, encephalitis and all. But the child who was otherwise okay, suddenly developing a CNS symptom, always think about poisoning. Abnormal smells, always poisoning should be considered. Then abnormal vitals, including hypoglycemia, tachycardia, bradycardia, hypotension, bradypnea, and also unexplained acidosis. We always need to consider poisoning if the patient is coming to these symptoms. Then we have to do a complete physical examination and look for anything in the history or in the examination finding which may clue us towards a poison intake. Small pupils, always look for the pupils. Small pupils will tell us that it may be an opioid intake, organophosphorus compounds, then sedatives like early stages of barbiturates and all. Dilated pupils are seen in datura and also sympathomimetic intakes. When the patient is coming to us with increased secretions, we always suspect organophosphorus poisoning. Whereas in the case of datura poisoning, you have a very hot and dry skin. Cyanosis may be a symptom of poisoning, especially nabzone and also naphthalene-borne poison, where there can be wet hemoglobinemia. So the patient may come to us with an acute onset of cyanosis. Then bradycardia can be seen in drugs, especially digitalis, beta blockers, and also organophosphorus. Then tachyarrhythmias, especially SVT, can be seen in SVT and also VT can be seen in antipsychotics and also tricyclic antidepressants. So do a complete examination, and if the examination findings are suspicious of poisoning and the history cannot explain the symptoms, always think about poisons. Then another symptom, as we said, is drowsiness. Drowsiness can occur due to anti-seizure medications. Any of the anti-seizure medications, if they're taken at a higher dose, they can present with drowsiness and also sedatives. Then ataxia is another symptom. Ataxia may be due to drugs like phenytoin and carbamazepine. They are two anticonvulsants which are very well known to produce ataxia, and they can also occur in antihistamines, anticholinergics. Then piperazine, actually piperazine is nowadays not available, but earlier days when piperazine citrate was given for deworming, the children used to come to us with ataxia. So these are some of the symptoms or signs where you need to suspect poisoning, even if there is no history of intake. Suppose a person or patient is coming to us with a definite history of intake. The mother or the parents saw that the child had taken some drugs or chemicals. Then we need to take a detailed functional history. We need to see the compound, which is the compound that the child has taken. What are the ingredients in that compound? Because the drugs, the compound, the amount of the different compounds in the fixed drug combinations may differ, and also the chemicals, also the concentration of different substances may differ from one brand to another. So you need to see the concentration of the poison or drug in that compound, and also the quantity, the volume of liquid, number of tablets. If the patient has taken some seeds, we also need to see the ask about the number of seeds that the child has taken, whether the seeds were swallowed by the child or whether the child has actually bitten and broke the seed and then swallowed, where the chance of poisoning increases. Time of ingestion is also important. Why? Because your management also varies depending upon the time of ingestion. And if the patient has received any pre-hospital management, that also has to be noted in our case sheet, and underlying illness which may affect your management also has to be noted. And when we see a poison child, you assess the complete physical examination, including the CNS examination, as we said, is very important. Vitals has to be documented, pupils. Then in the oral cavity, we can look for any remnant of the drug there, any smell of the drug. Then you can look at the salivation, which may be increased, as we said, in organophosphorus poisoning. Look at the breathing, whether it is an acidotic breathing or a normal breathing, and look for lump pulmonary edema, features of aspiration. And in the CBS, you can look for brady or tachyarrhythmias. Then in the abdomen, we can look for the bowel sounds, which may be increased or decreased in different types of poisoning. And the skin, you can look at the color and sweating. Now we will discuss about the management of the common poisoning by going through a few cases. First is a case of a 3-year-old child. This child was brought to us with a history of ingestion of one full bottle of cold syrup, which contained 60 ml syrup, which was ingested half hour back, and this syrup contained chlorpheniramine maleate and phenylephrine. So what to do for this child? So for any child who is brought to us with poisoning, the first thing is always assessment and stabilization of the airway, breathing and circulation. Look at the airways. Especially if the patient is drowsy, the airway may not be patent. If there are any secretions, give suction and clear the airway. And any patient who is having altered sensorium has to be kept in the recovery position. And if there is hypoxia, we will definitely give oxygen. We will definitely give oxygen, and if the patient is not having an adequate respiration, then we may have to use an ambu bag and give a positive pressure ventilation and stabilize the circulation. So you assess the ABCs and decide upon the management there. And along with the stabilization, we need to go for gastric decontamination also. Can we remove a drug from stomach? That is the question. Because we can do try to remove the drug from the stomach, especially if the child is brought soon after the ingestion of the drug. We can decontaminate by inducing vomiting, but it is rarely used nowadays because the child can aspirate the vomiters. What we usually do is gastric lavage. We can try to wash out whatever poison the child has ingested, and we can also give activated charcoal. Gastric lavage is effective when the patient is brought to us within 1 hour of intake of drug or poison. But sometimes in the case of drugs, which may delay gastric emptying, like anticholinergics and all, there you can even give gastric lavage after 1 hour also. It is contraindicated in the case of corrosives because it is going to produce more injury, and also hydrocarbons. Why? Because it will lead on to aspiration. And also in any child who is drowsy, it should not be done unless you protect the airways. So in a drowsy child, first we have to protect the airways. That child may need intubation, and then you go for gastric lavage. So how to do a gastric lavage? Patient has to be in the left lateral position, head down position. We need to insert an OG tube, and first you aspirate and empty the stomach. Then do a wash with normal saline. We can use around 10 to 15 ml per kg aliquots of normal saline. And what you do is you instill this aliquot, and then it is aspirated back. Never make the patient vomit. It should be aspirated back, and it has to be repeated until the fluid is clear. And after you complete the gastric lavage, if the patient requires activated charcoal, it can be inserted through the Ryle's tube, and then you remove the Ryle's tube. That is how you do this gastric lavage. Activated charcoal can be, it's a very good drug which can be given for almost all drug injections. But there are certain drugs where it is not very useful. It is not useful in the case of pesticides, hydrocarbons, alcohol, iron, lithium, and solvents. Actually, remembered by using the acronym FAILS. So the dose of activated charcoal is depending upon the age. In children less than 6 years, you can give 1 to 2 gram per kg, and children above 6 years, we can give 50 to 100 gram as a single dose. What we do is we prepare the syrup in 100 ml of water or juice. We use water if it is instilled through the rice tube. Otherwise, if you are giving the activated charcoal and making the patient drink, we can even dilute it in the syrup so that the children will drink that activated charcoal. For some drugs, then the drug will remain in the GIT, and it will be absorbed over a longer period of time, like theophylline, barbital, phenobarbital, and all. We can give repeated doses of activated charcoal. For most of the other drugs, a single dose of activated charcoal will be enough. Now, suppose the patient is coming late and the drug has also already been absorbed. Can we do anything? There we try to remove these drugs only if the drugs and chemicals can cause serious adverse effects. So here you can go for either forced alkaline diuresis or hemodialysis. These are effective only when the drugs are low molecular weight and water soluble. Only then with these hemodialysis or even forced alkaline diuresis is effective. It can be used in the case of salicylates, phenobarbital, INH, and all. So what we do is we will give IV fluids, we will give IV bicarbonate also, IV or oral, depending upon the patient's condition, and give furosemide. So you're producing an alkaline diuresis. Our aim is to produce a 3 to 6 ml per kg per hour urine output with a urine pH of above 7.5 to 8.5. Since during this alkaline diuresis, potassium is also lost in the every alternate fluids, or even the third bottle, we can add potassium also. Whenever we go for forced alkaline diuresis, we need to monitor the vitals and electrolytes. And it is a procedure which has to be avoided in any child who has any marginal blood pressure or poor perfusion. And also renal failure naturally will not be able to, not be successful at all. And also cardiac failure. Why? Because these children will not be able to tolerate this high rates of IV fluid. So this is one modality that we can do, but it is not routinely done. It is done only when the patient has taken these drugs, and also they have taken at a higher dose where the drug is leading on to the serious adverse effects. Okay. As I said earlier, dialysis is also effective only for drugs which have a low molecular weight, protein binding, and water soluble drugs. Digoxin, INH, aspirin, all those drugs which I described earlier, they can be dialyzed also. Another thing is that the alcohol, especially the toxic alcohols like ethylene glycol, diethylene glycol, which were there in the cough syrups, they are a group of drugs which can be removed by dialysis. And dialysis is not effective for hydrocarbons and also organochlorines and anticholinergics and also opioids. So now we are going to the next case. This is a 4-year-old child with a history of ingestion of Harpic Power Plus. You can see that this thing. There are different concentrations of toilet cleaners available. They may contain alkalis or acid. This particular compound, solution actually contains around 10 to 15% of hydrochloric acid. So it's a very highly corrosive substance. And this bottle was actually kept without the lid, and the child tried to take that. You can see that the child has extensive burns involving his mouth and also the tongue. So accidental ingestion of acids and alkalis are actually a fairly common thing. Acids usually produces coagulation, necrosis, and scar formation. And since the scar is formed, it will limit the depth of the involvement, but it produces severe, extensive mucosal burns. Whereas alkalis will produce liquefactive necrosis. Hence, these alkalis, further alkalis can penetrate deeper into the mucosas, and there is a higher risk of perforation with alkalis rather than acids. Both can produce long-term complications like stricture and carcinoma. If you have only burns in the oral and oropharyngeal mucous membrane, it is considered as a mild poisoning. In where the esophagus is also involved, so that the child is having odynophagia, drooling, dysphagia, and also mild chest pain, it's a moderate poisoning. Whenever there is airway involvement, as evidenced by stridor or respiratory distress, hematemesis, and also perforation, it is a severe poisoning. So what to do for corrosive poisoning? It's very important to know what not to do for corrosive poisoning. Okay. In corrosive acid poisoning, we should never induce vomiting or gastric lavage, and also never attempt neutralization. Just because the child has taken an acid, you should never give alkali, because this neutralization is an exothermic reaction, and it will actually exacerbate the burning. Okay, so don't do that, and also don't perform any blind intubation at all. And the medical management is patient has to be kept nil perorally. If the patient is able to take any fluid sips, we can give sips of milk. Milk is actually a soothing agent. So if it's a mild case, you can offer milk. Otherwise, we will keep the patient nil perorally. Give IV fluids and also proton pump inhibitors. Analgesics are very essential because this is a very painful condition. So we can give opioid analgesics like morphine or fentanyl for a few days. Broad spectrum antibiotics also should be given if the patient is having a deep ulcers or if there is a chance of perforation. And steroids, they are not routinely indicated, but for severe cases, especially deep injuries are there, we can give steroids. Steroids are supposed to decrease the incidence of strictures. And it is very essential that we do an upper GI endoscopy within 12 to 24 hours of ingestion of the corrosive, so that we can assess the extent of the esophageal injury. But this upper GI endoscopy should be avoided after 48 hours, because that is the time where when the perforation occurs. So in the initial part, within 12 to 24 hours, we can do an upper GI endoscopy if the facility is available, and look for what is the extent of the injury. And if there is any evidence of perforation, we always take an X-ray, chest and abdomen, to look for perforation. That is to look for any mediastinal or abdominal air. Then CT scan if there's a deep injury and perforation, and other investigation in the case of a severe thing. And endoscopy, as I said, is mainly for grading of the injury, and always it is essential that we always send a surgical consultation, because sometimes the patient may have a full thickness injury, perforation and all, and there in the later phase we may need surgical management also. Complications are acute is perforation, mediastinitis, peritonitis, and also airway obstruction. And chronic cases chronic complication is esophageal strictures and also gastric outlet obstruction. And as I said, there is a risk of carcinoma in the later life. So what happened to our patient is that the patient had extensive oral lesions, and the endoscopy also revealed esophageal ulceration. So the patient actually symptomatically improved, was tolerating oral feeds, and patient was advised regular follow-up. But they actually failed to come back for follow-up, and we saw the patient some 4 months after the patient was discharged from here. And the history, what the mother said was that the child was actually all right in the first 2 months after this injection of corrosive, and after that for the last 2 months child was having persistent vomiting. So they were they went to different hospitals, they were treated with multiple drugs, IV fluids, and even a CT scan head was taken because somebody suspected at ICSOL and told, but they did not find anything. So due to the persistent vomiting, they came back to our side. And actually, the parents failed to tell us that the patient was admitted with the history of corrosive acid ingestion. Okay, so when we actually went through the case sheet only, we recognized that there is a history like that, because the parents actually did not give any importance for that. They thought that everything was over. So when we took a barium solo for this child, this was the barium solo of the child. You can see that there is an esophageal structure, long esophageal structure, and there is a dilatation of the esophagus which is proximal to that structure. So what was actually happening was that when the child was trying to eat, everything was collecting in the proximal part of esophagus, and the child was regurgitating that out, which was taken as a what do you call it, vomiting. So this is very important, that whenever you have a child who had corrosive acid or alkali poisoning, we need to expect that this patient can develop certain complications, and it has to be conveyed to the parents in the correct manner. Here actually we fail to inform the parents about the gravity of the patient's esophageal injury. Okay, so the patient developed a complication also. Now the patient is under serial dilatation of the esophagus and is doing okay. Now we are seeing the next patient. This is a 2-year-old child with history of ingestion of kerosene. Okay, and here the history is like that. Kerosene was kept in the soft drink bottle. You can see that the patient is having both tachypnea and also respiratory distress. So this is a very common. I think this is one of the commonest ingestions that we usually see in common and serious ingestions that we see. Because kerosene is very accessible in the households, and also everyone keeps the kerosene in the soft drink bottles or water bottles or in open containers. And whenever you keep any fluid, especially kerosene has a very bright blue color, it's very attractive color, the children will tend to take this. And once they ingest kerosene, kerosene has a very low viscosity and it's highly volatile. So it will just spread into the respiratory mucosa. It can lead on to direct chemical pneumonitis and also secondary bacterial infection. But majority of the cases has chemical pneumonitis, and systemic toxicity is also reported, but it is rare and it occurs with a higher dose of ingestion. So the clinical features, we usually definitely will have smell of kerosene and the breath, clothes and all. And symptoms in the early, within 1 to 2 hours, they will have cough, choking, gagging, vomiting, and also early hypoxia is something which is very common in kerosene. That is not actually due to the chemical pneumonitis. Chemical pneumonitis takes place around 6 hours after ingestion only. It will not be there in the initial part. The early hypoxia is actually due to the coating of the whole respiratory epithelium and alveoli by the kerosene, because it's a volatile one. Now, once it is excreted through the breath and all, the hypoxia actually decreases. Then after 6 hours, after a few hours, depending upon the amount of kerosene ingested, it may even occur later. Then after a few hours, the child will develop respiratory symptoms like tachypnea, wheeze, crepitation, cyanosis and all. And GI symptoms may also be the nausea, vomiting, and neurological. That is also drowsiness and seizures as seen in cases where a large quantity is ingested. And always, whenever a patient is brought to us with history of ingestion of kerosene, even if the child is completely asymptomatic, they have to be observed for at least 6 hours. Because as we said, the chemical pneumonitis takes some hours to develop. And if any child is symptomatic, they have to be admitted. Any symptoms, as we said, are respiratory distress, hypoxia, altered sensorium. And in any patient who is having X-ray changes, even if asymptomatic, has to be admitted and observed. Okay. And in look for oxygen saturation, X-ray, as I said, is taken only 6 hours after the ingestion. Why? Because if you take an X-ray early, the X-ray will be normal, and then it will take some time for the pneumonitis to develop. Okay. In the case of severe or moderate respiratory distress, we always do an ABG to look for the and severity of the hypoxia and hypercapnia. Then symptoms which are occurring around 24 to 48 hours after ingestion, it's likely to be due to secondary bacterial pneumonia. The patient was okay in the initial 1 or 2 days, then developing symptoms, especially fever and all, which could be due to secondary bacterial pneumonia, and that child will require antibiotic. And when we look at the management of the kerosene poisoning, it's very imperative that you do not induce vomiting or do not do a gastric lavage, because the patient will aspirate the kerosene. Patient will aspirate the kerosene during vomiting or gastric lavage, because the problem is the aspiration only. Yeah? It's not the ingestion, rather than aspiration is the problem with kerosene. Then activated charcoal also does not have any role. What you do is you give supportive management, oxygen inhalation. We can give nebulized bronchodilators, fluids if the patient is vomiting. And steroids and antibiotics are not routinely indicated, but if you are suspecting a secondary infection, you give antibiotic. And also, if the patient is severely ill, steroids may also help. Always, another important thing is that always rule out another poison when the patient is excessively drowsy, because kerosene can be used as a solvent of other drugs, other poisons like organophosphorus and all. So, if the patient is excessively drowsy, just see what the child has ingested. Even if the child there is smell of kerosene, it may be something else also the patient, which the patient has ingested. Most of these patients recover within 3 to 5 days, and mortality is less than 2% if it is properly managed. But a few cases will go for ARDS, secondary bacterial pneumonia, and we have also seen extensive air leak syndromes due to kerosene poisoning. And prevention is very important. As I said, this is one of the commonest severe poisoning that you see. Where always kerosene has to be stored in original containers with tight lids. It should never be stored in water bottles and all. This is something which has to be educated to the parents and caregivers, and we actually need community level awareness program and also policy interventions to ensure child safe packing, and also reducing the domestic use of this colored kerosene, because unless we do these things, children will come to us again and again with kerosene poisoning. Okay, now we are going to the next case. This is a 10-year-old girl with vomiting. And the child had repeated vomiting, and then the mother noticed that there were some tablets in the vomiters. And on questioning, the child admitted that she took 2 strips of mother's iron tablet. Why? Because the mother scolded her for something, so she took 2 strips of mother's iron tablet. So we have this red-colored tablet which contains 60 milligram of elemental iron, and also the blue-colored pediatric tablets are there. But the child took was the 60 milligram iron tablet. So iron poisoning, iron is a very corrosive substance, and iron has a corrosive effect on the GAT. And another thing is that iron will lead on to free radical injury, so that it will lead on to mitochondrial dysfunction. And when the mitochondria is not working, there will be severe metabolic acidosis. It can also produce cardiovascular and hepatotoxicity. And the severity of the poisoning will depend upon the dose that the child has ingested. And dose less than 20 milligram per kg is usually non-toxic. So you don't have to do anything for that. The patient may have some GI symptoms and will recover. 20 to 40 milligram per kg also there will be some GI symptoms only. But any dose more than 40 milligram per kg is moderate to severe poisoning. More than 60 milligram per kg can even be fatal. So we need to know the exact dose that the child has taken. The symptoms of iron poisoning it varies depending upon the time in which the patient is presenting. In the initial 6 hours, the patient mainly has GI symptoms. Patient will have diarrhea, vomiting, hematemesis, sometimes melena, and also if these are severe, patient can even come to us with hypovolemic shock. Then what usually happens is that between 6 to 6 hours, after 6 hours, there is an apparent improvement in the patient's condition. In the next 6 hours, child will usually be all right, and parents may think that the child has actually improved. But it is the time where the other injuries, as we say, the mitochondrial injury, everything is taking place. And by 12 to 20, between 12 to 24 hours, in the next 12 hours, the patient will have all the features of mitochondrial injury. There will be lethargy, hypoglycemia, tachycardia, shock, and metabolic acidosis. Then after 24 hours, then the hepatic patient will present to us with hepatic dysfunction, coagulopathy due to hepatic dysfunction, renal failure, and persistent hypoglycemia. And this is the stage at which more complications can occur. And if the patient is recovering from that by our management, then next symptoms occur by somewhere around 2 to 8 weeks, where the patient will present to us with gastric outlet obstruction. So the investigations, as we said, these are the complications that we expect. So you look at the LFT, blood glucose levels, electrolytes, blood gases, and also it's very essential that we take a plain X-ray abdomen, especially when the child has taken tablets, because iron tablets are radiopaque, so they can be seen in the X-ray. And the number of tablets, sometimes if the iron tablets earlier was dispensed in the bottles, then actually the number of tablets, what is the number of tablets taken, that is something which parents also may not be able to tell us. But if you see the tablets in the X-ray, we'll be able to know the number of tablets which has reached the stomach. Okay. Know how to manage, rather than along with the initial stabilization, we go for gastric decontamination. That is very essential in the case of iron poisoning. We can give gastric lavage with saline and also with even 1% sodium bicarbonate. 1% sodium bicarbonate is a very dilute solution. It is an isotonic soda bicarbonate solution. You can give stomach wash with that. If the child has ingested a large number of tablets, we can even go for a whole bowel irrigation with pegatone. And we do have an antidote for iron. The desferrioxamine or deferoxamine is available, but it's a little bit difficult to procure nowadays, because earlier this was very easily available because we used to give it for beta thalassemia. Nowadays it may be very difficult to procure. It's there in the Tamil Nadu, so we procure from there. We give deferoxamine if the patient has a serum iron level of more than 500 microgram per deciliter, or if the patient is having symptoms like metabolic acidosis, shock, or even altered LFT. We can give doses at 15 milligram per kg per hour, and it is continued till the urine clears. When the iron is chelated from the body, the urine will have a typical Windrose color, which gradually decreases, and this desferrioxamine should be continued till the urine is colorless. Now we are going to the next case. This is an 8-month-old baby with fever. This baby was prescribed paracetamol drops, 100 milligram per ml. 1 ml per dose was prescribed by the doctor, but by mistake, the mother gave 5 ml 6th hourly, and this was given for 2 days. And this medication error was noticed only after the 8th dose, and now the baby is brought to us. We need to know whether this is in the toxic dose or not. So what is paracetamol toxicity? Paracetamol toxicity is not only a single acute dose of paracetamol. If you're taking paracetamol more than 200 milligram per kg as a single dose or within 24 hours, it's definitely toxic. But also, if paracetamol is taken at a dose more than 150 milligram per kg per day for 48 hours, or 100 milligram per kg per day for 72 hours, it is definitely toxic. So all these 3 conditions are considered to be paracetamol poisoning. Definitely this child who was brought to us with 500 milligrams 6th hourly is definitely has taken toxic dose. This is a very common cause for pediatric acute liver failure. Actually, this is actually compounded by the different concentrations of the paracetamol available in our medical stores. We have a strength ranging from 500 milligram to 120 milligram per 5 ml, and also 100 milligram per ml bottle. So it's very, it's actually difficult for the parents to understand the dosing, especially if the pharmacy is not prescribing what pharmacist is not given what we are prescribing. Yeah? If the drug is given from the hospital itself, then it is okay. Then we have only a particular dose there. Then there won't be much confusion. But if the parents are getting the drugs from the pharmacy outside the hospital, there may be confusion, especially if they are also confused with the dose, then this is something which is very common, which we very commonly see in our practice. So, what happens in paracetamol poisoning? In paracetamol poisoning, also we all know that the paracetamol poison will lead on to acute liver failure. But this acute liver failure will not occur in within the first 24 hours. In the first 24 hours, these babies with the paracetamol poisoning also have non-specific symptoms and some GI symptoms. They will have anorexia, nausea, vomiting, sweating, abdominal pain, pallor, and all. And the hepatic phase actually begins after the 24 hours after the injection, if it's an acute injection. There in the 24 to 48 hours, they will have right upper quadrant pain, increased liver enzymes, bilirubin will increase, prothrombin time will increase, and also oliguria can occur. It is between 72 to 96 hours that the peak LFT abnormality occurs and extensive liver damage and acute liver failure occurs. Right? That is by around 3 to 4 days. That is the time where the patient has highest mortality. And after that, either the patient can slowly lead on to resolution of the symptoms, or it may progress to acute liver failure. So our management in the initial phase can decide in which way the patient can go. So how to treat acute paracetamol poison? If the patient has ingested a large dose, then we can give gastric lavage. As in the case of the toxic dose ingested over a few days also, there is no point in us giving gastric lavage. Then when we look at the textbooks and all, measurement of paracetamol level and plotting in the nomogram, everything is described. But these are applicable only for acute ingestion. And another thing is that the level of paracetamol, testing for the level, it's not the paracetamol level measurement is not there in all the areas, and also even if it is there, the results will come late. So we cannot make a decision depending upon this plotting in the nomogram and all. So for any patient who has come with ingestion of toxic dose of paracetamol, we give the antidote, that is the N-acetylcysteine. It can be given as oral dose 140 milligram per kg as a single dose, followed by half this dose for hourly 17 doses, or an intravenous infusion can be given depending upon the facility available in the hospital. It's imperative that we monitor the patient with SGOT, PT-INR, and paracetamol levels can be done if feasible. And this NAC infusion should be continued till SGOT decreases and INR normalizes. And also the urea, creatinine, everything is normal. It has to be continued till now. And if the patient meets any criteria for liver transplantation, patient has to be sent for liver transplantation. Okay, now we are moving on to the next case. This is a history of story of three kids from the same family. Mother was admitted in our eyes in the adult ICU with history of suicidal attempt. The mother was ventilated, and she gave the same poison to all three kids. We had three kids: a 10-year-old girl, a 5-year-old girl, and a 3-year-old boy. Actually, the boy did not take much of the poison which was offered. It was offered in ice cream juice and all. He spit out the poison, and he was asymptomatic. This is the ECG of this 10-year-old child. You can see that the child is having ventricular tachycardia. This child had very refractory ventricular tachycardia, which actually we were not able to revert by giving drugs or even repeated cardioversion. So this child actually expired. And the second child, 5-year-old child, had fulminant hepatic failure with PT-INR more than 100. And then actually the child was advanced liver transplantation, but the family was not affording. Gradually that patient improved. So which is the poison which can manifest with all these symptoms. There we need to think about the rodenticide poisoning. Okay, rodenticide poison, there are different types of rodenticide poisoning. We have the zinc phosphate, which is a very toxic one, which may present us with cardiac toxicity and also hepatic toxicity. Actually, the poison which is ingested by the particular by the children that I described, that was the zinc phosphate. Okay. There can also be warfarin-like compounds. Then the cakes and all, they contain the warfarin-like compounds, which will present as bleeding. It's a very bleeding which will last for a few days. And the important thing is that sometimes it may be some blackish powder, which actually we don't know what is the content in that. They also seems to contain zinc phosphate, but it may contain other things also. Okay, and we need to know about the cardiotoxicity of the zinc phosphide. It can occur. It can present as STT changes and also global T wave inversion, and also even fetal arrhythmias like VT, as in the case of our child. Okay, this cardiac toxicity can occur even late, it can occur even a few days after the ingestion. So the first ECG, you can see there is global T wave inversion, and the second ECG, we have a sudden onset of ventricular tachycardia. So this is one type of poison which can be fatal. So what we have to do is, if any child who has come to us with rodenticide poisoning, we need to give a gastric lavage with saline. It can be followed by a gastric lavage with sodium bicarbonate, 1% sodium bicarbonate, and also potassium permanganate if available. But I think potassium permanganate is not very freely available nowadays. So we can give stomach wash with saline and sodium bicarbonate. And these children should be admitted and monitored for renal functions, hepatic function, ECG, and also blood gases. When the patient is having metabolic acidosis and ECG changes, that will suggest toxicity. If we are able to identify early metabolic acidosis and ECG changes and manage accordingly, we can actually salvage most of these patients. We had children who died due to rat poisoning with even minimal intake of poison. But nowadays, when we go for the evidence-based management, we are able to save most of these patients. The drugs that we usually prescribe is carnitine. Carnitine will protect from the cardiac side effects. Then steroids will also decrease the cardiac side effects. Magnesium will act as a membrane stabilizing agent, and bicarbonate has to be given to counter the acidosis. Sometimes you may have to give this soda bicarbonate for a few days, and once the acidosis is reverted, then we gradually taper and stop the steroids. Stop the bicarbonate. Then if the patient has ingested the warfarin-like compound, then we give the antidote is always vitamin K, and FFP is given to support the is given to normalize the INR, and prothrombin time has to be monitored. Now coming to the last case, this is a 8-year-old child with Down syndrome. Actually, this child was, history was like that. The child was found playing with a bottle, actually bottle which was there in the compound. And since there is a history like that, child was taken to the local hospital, and promptly a stomach wash was given from the local hospital. And since the they were suspecting poisoning, child was referred to our side. When we saw the patient in the emergency room, the vitals were stable, and the parents said that the child has not ingested anything. Just because of suspicion, the stomach wash was given. And hence the patient was admitted in the ward, and the patient was okay. Patient was running around in the ward. But what happened was that after 20 hours, that the next day, the child developed severe respiratory distress, stridor and bradycardia, and child had to be intubated from the ward itself, and the child was transferred to our side. Okay, so you can see the video of this child. The child was actually having drowsiness and also some fasciculations in the fasciculations of the eyelids and also respiratory distress, and you can see some fasciculations of the abdominal muscles at all. Now the parents actually brought the bottle and the child was has ingested organophosphorus. So this was a case of organophosphorus poisoning where actually we did not give the treatment in the initial part. Why? Because the history was not reliable at all. Only when the patient developed symptoms, we were able to start treatment. Okay. So organophosphorus is there in all the pesticides and insecticides. So this was an accidental ingestion, but sometimes we do see intentional ingestions also. So organophosphorus will lead on to inhibition of the acetylcholinesterase. So it will lead on to accumulation of the acetylcholine and overstimulation of the muscarinic, nicotinic, and CNS receptors. Okay. The duration of symptoms depends upon the compound. There are different compounds. There are short-acting compounds, long-acting compounds, and all. And another thing is that when the enzyme complex ages, there is decreased reversibility. That means early treatment will actually decrease the duration of symptoms. So what are the symptoms of organophosphorus poisoning? Due to the muscarinic symptoms, muscarinic overaction, the child will have salivation, lacrimation, urination, diarrhea, GI cramps, emesis, and also the 3Bs, that is bradycardia, bronchospasm, bronchoria. So whenever a patient is having bradycardia, bronchospasm, and bronchoria, we need to suspect this organophosphorus poisoning. Nicotinic signs will also be there, that is muscle fasciculation, weakness, hypertension, tachycardia can also occur. Then CNS effects like anxiety, confusion, seizures, coma, respiratory depression can occur. Okay. The test that you can do is pseudocholinesterase level, RBC and plasma cholinesterase levels, if available, can be done. That will confirm the diagnosis, especially if you have a doubt whether this is organophosphorus or something, then this can be done to confirm the diagnosis. It will be decreased. Then you look for metabolic acidosis, hypoxia, you look at the electrolytes and all. Chest X-ray, because the child can have aspiration. Child can also have pulmonary edema due to these effects. Okay. The important thing is ABC and decontamination. But along with that, we can give the antidote. Antidote is atropine. For the muscarinic symptoms, we give it 0.05 milligram per kg every 5 to 10 minutes until atropinization occurs. We have to keep the lung dry. That is the maintenance level of atropine. Okay, you can give even as a maintenance infusion. Pralidoxim is given for nicotinic symptoms. The carbamates actually they have a reversible binding. So for carbamate poisoning like furidine poisoning and all, you don't have to give pralidoxim. Okay. So these are the common poison that I wanted to describe. There are other poisons also. Mosquito repellent is something that the children nowadays ingest. They can present to us with GA symptoms and CNS symptoms. There is no antidote as such. We give symptomatic management. Camphor ingestion is very common in Alapura and all. They can come to us with intractable seizures. Then mushroom, different manifestations can occur. Hepatic failure can occur due to mushroom. And in Trivandrum, we used to have small babies, maybe around 2 to 3 months old babies coming to us with intractable seizures following ingestion of mullalethailum. There was a Vaidyan who used to prescribe this mullalethailum for ചുവപ്പ് എന്ന് പറഞ്ഞു കൊടുക്കുന്നതാണ്. So they came to us with very intractable seizures. Nowadays, we're not seeing these. Then there are cardiotoxic plants like Odalam, Oleander, Kadalavanaka, all those plants are there. They can come to us with vomiting, bradycardia, arrhythmia, and the major management is giving atropine and hyperkalemia management. Cardiac pacing can also be done. I'm not going into the details of that. Children also ingest a lot of perfumes, cologne, then deodorants, hair dye, OC pills, marker ring, aftershave, fabric, so a lot of them, whatever is there in the home, they can ingest. These substances have minimal toxicity only. Most of them require only observation. So pediatric poisoning demands a proactive approach and risk anticipation and early diagnosis. And timely interventions are the key to improving outcome. These are my resources. And when we do have a lot of poison help centers, there is a National Poison Information Center in the AIMS, which can be reached by these toll-free numbers and also mail. Amrita Institute Kochi also runs a poison control cell, and also there is a help number of CMC Vellore. So that if we have any doubt or any what do you call it, we don't know how to manage a child with some poison, because children can ingest anything, because we can always contact them and they will advise us about how to manage. Okay, thank you.
Thank you, Bindusha madam, for the very clear talk covering almost all the common childhood poisoning. മാഡം പറഞ്ഞ പോലെ കുട്ടികളെ എന്ത് സാധനം വേണമെങ്കിലും വായിലെടുത്തിടാവുന്നതുകൊണ്ട് നമുക്ക് ഇതിനൊരു എൻഡില്ല എന്തൊക്കെയാണ് പോയ്സണിങ് എന്നുള്ളത്. എനിവേ താങ്ക് യു മാഡം. എന്തെങ്കിലും ക്വറീസ് ഉണ്ടെങ്കിൽ യു ക്യാൻ അൺമ്യൂട്ട് ആൻഡ് ടാസ്ക്.
ചാറ്റ് ബോക്സിൽ
ചാറ്റ് ബോക്സിൽ ക്യാൻ യു എക്സ്പ്ലെയിൻ ഹൗ ടു അഡ്മിനിസ്റ്റർ ഫോഴ്സ്ഡ് ആൽക്കലൈൻ ഡയോറിസിസ്?
Okay, forced alkaline diuresis, what you do is we will give IV fluids. IV fluids, saline is given at 1.5 times the maintenance rate. That means if the child is weighing 10 kg, usually you give 1000 ml over 24 hours. So you use the 1.5 times that. In the ICUs and all, we usually calculate by the 4-to-1 rule. So we calculate the hourly fluid intake. So for a 10 kg child, 40 ml per kg is the usual requirement of fluid. So give 60 ml per kg per hour fluid. And along with that, you can give 1 ml per kg soda bicarbonate can also be given, maybe given at 6 to 8 hour interval. Just make sure that the patient, the urine is alkalized. In most cases, we don't actually have to give what you call Lasix, furosemide, because giving saline itself at a higher dose will lead on to diuresis. The aim, we actually aim at making sure that the patient is passing more than 3 ml per kg per hour urine. If the patient is passing 4 to 6 ml per kg per hour, we are okay. And just look at the urine pH, it should be more than 7.5. That is our aim. This can vary depending upon the patient. In some patients, we may be able to alkalize the urine even without giving soda bicarbonate. So the amount of soda bicarbonate that we have to give will vary depending upon the patient. Okay, so this is what we usually do.
Okay, thank you, madam. How to do stomach wash with normal saline and sodium bicarbonate?
Stomach wash, I think I have already described. What we do is you will put in a rice tube, give 10 to 15 ml per kg of saline. So for a 10 kg child, you can give 100 ml or 150 ml saline. And then before you give instill saline, you always aspirate the stomach and empty the stomach. Whatever is there in the stomach has to be aspirated. Then you give saline, and then the saline has to be aspirated back. Then give the next aliquot. Like that, you will repeat till these washings are clear. Okay. Then soda bicarbonate, we give only for particular poisoning. I describe for iron poison and also for this thing, rodenticide poison. There you can give wash with soda bicarbonate. When you give soda bicarbonate, the soda bicarbonate available with us is a very costing thing. That cannot be used as. So you have to make an 1% solution or an isotonic soda bicarbonate. How we make is that suppose for stomach wash, we can use this sterile water. In a 500 ml bottle of sterile water, we remove the 75 ml from that bottle and add 75 ml of soda bicarbonate. So the resulting fluid will have a concentration of sodium of around 150 milliequivalents per liter. That means that is like saline only. So it's an isotonic solution. It's somewhere around 0.9 or 1% solution. That solution can be used for giving the stomach wash. For these leftover rodenticide poisoning, after the saline wash, you can give a wash using this one also.
അതിന്റെ കൂടെ ഒരു ചോദ്യം കൂടെ ഉണ്ട് മാഡം. ടിൽ വാട്ട് ടൈം ഗ്യാസ്ട്രിക് ലെവേഴ്സ് ക്യാൻ ബി ഗിവൺ? എനിക്ക് ആക്ടിവേറ്റഡ് ചാർക്കോളിന്റെ കാര്യം കൂടെ ഒന്ന് മാഡം ഹൈലൈറ്റ് ചെയ്ത് പറഞ്ഞേക്കില്ല.
Gastric lavage എന്ന് പറയുന്നത് gastric lavage is given usually for because these drugs that the children ingest, they will be in the stomach for maximum 1 to 1.5 hours. It is most effective if can be given within 1 hour. But sometimes you may even give it after 1 hour also. Sometimes, especially if the patient is taking any drugs which will delay the gastric emptying, as in the case of anticholinergic drugs. That means all the antihistamines will have anticholinergic action. Okay. In those conditions, even if it is given after 1 hour, that will be effective. But try to give it as fast as possible. That means if tied with any injection is brought to us and there is no contraindication for gastric lavage, it is always better to give a gastric lavage from the primary health by the primary physician itself before referring. Because that is the one which will actually decrease the absorption. There is no point in giving a gastric lavage or 4 or 6 hours after the ingestion of the drug. Then activators, charcoal is a very good drug that can absorb most of the drugs. Only thing is that you should not use it for corrosives and hydrocarbons. അത് പറ്റത്തില്ല. And there are some drugs where it is not effective. ഞാൻ കുറച്ചുകൂടെ പറഞ്ഞില്ല, ഫെയിൽസ് എന്ന് പറഞ്ഞ് നമ്മളൊരു അക്രോണിയം വെച്ച് യൂസ് ചെയ്യുന്ന അതിനകത്ത് ഇത് ഇഫക്റ്റീവ് അല്ല. അങ്ങനെയുള്ളത്തെ ഡ്രഗ്സിനൊക്കെ യു ക്യാൻ ഗിവ് എ സിംഗിൾ ഡോസ്. എനിവേ സിംഗിൾ ഡോസ് ക്യാൻ ബി ഗിവൺ ആഫ്റ്റർ യുവർ ഗാസ്ട്രിക് ലാവേജ്. അപ്പോൾ വാഷ് ചെയ്ത് കഴിഞ്ഞ് കഴിയുമ്പം ഉടനെ ഈ ആക്ടിവേറ്റഡ് ചാർക്കോളും കൂടെ കൊടുത്തിട്ട് അങ്ങ് റൈസ് ട്യൂബ് മാറ്റുന്നതാണ് നല്ലത്. അങ്ങനെയല്ല, റിപ്പീറ്റഡ് ഡോസസ് കൊടുക്കേണ്ട ഡ്രഗ്സ്, ഇപ്പൊ തിയോഫിലിൻ അങ്ങനെയുള്ള കുറച്ച് ഡ്രഗ്സിനകത്ത് യു ക്യാൻ ഗിവ് ഫെനിറ്റോയിനും കൊടുക്കാം, റിപ്പീറ്റഡ് ഡോസസ് കൊടുക്കാം. അങ്ങനെ കൊടുക്കുന്ന ഡ്രഗ്സ് ആണെങ്കിൽ യു ക്യാൻ കീപ് ദാറ്റ് NG ട്യൂബ് ഇൻ സിറ്റു ആൻഡ് കീപ് ഇറ്റ് 4 hourly. ഒരു 3-4 ഡോസസ് വരെ കൊടുക്കാം.
ആ ഒരു പോയിന്റ്, അതായത് സ്റ്റൊമക്ക് വാഷ് ചെയ്യുന്ന ട്യൂബിൽ കൂടെ തന്നെ നമ്മൾ ഫസ്റ്റ് ഡോസ്
അതങ്ങ് കൊടുത്തിട്ട് അങ്ങ് മാറ്റാം.
കൊടുക്കുക എന്നുള്ളതാണ്.
അല്ലാതെ നമ്മൾ ജ്യൂസ് കലക്കി കൊടുത്താലും ഒക്കെ കുട്ടികൾക്ക് കുടിക്കാൻ വലിയ പാടാണത്, കളറും ഒക്കെ കാണുമ്പോഴേ.
അടുത്തത് ഒരു വാട്ട് ഡോസ് ഓഫ് കെറസിൻ ക്യാൻ കോസ് ന്യൂമണൈറ്റിസ്, അങ്ങനെ ഒരു
അത് പറയാൻ പറ്റത്തില്ല. കെറസിൻ സാധാരണ അവര് എത്ര ചെറിയ ഡോസ് ആയാലും ദാറ്റ്സ് ആക്ച്വലി ദ ആസ്പിറേഷൻ. ഇഫ് ദ പേഷ്യന്റ് ഹാസ് ജസ്റ്റ് ഇൻജസ്റ്റഡ് ആൻഡ് നോട്ട് വോമിറ്റഡ് ആൻഡ് ഓൾ, സംടൈംസ് ഇറ്റ് മേ നോട്ട് പ്രൊഡ്യൂസ് ആസ്പിറേഷൻ ആൻഡ് കെമിക്കൽ ന്യൂമണൈറ്റിസ്.
പിന്നെ ഒരെണ്ണം ഇമ്പോർട്ടന്റ് ക്വസ്റ്റ്യൻ ആണ് ബട്ടൺ ബാറ്ററി മാനേജ്മെന്റ്.
ബട്ടൺ ബാറ്ററി ഞാൻ ഇൻക്ലൂഡ് ചെയ്യാഞ്ഞതാണ്, കാരണം അതൊരു ഫോറിൻ ബോഡി ആണല്ലോ എന്നുള്ളത് കൊണ്ടാണ്. ബട്ടൺ ബാറ്ററിയുടെ പ്രശ്നം എന്ന് വെച്ചാൽ ദാറ്റ് ഇസ് എ വെരി കൊറോസീവ് സബ്സ്റ്റൻസ്. ബട്ടൺ ബാറ്ററി എവിടെയെങ്കിലും പോയി ഇരുന്നാൽ അവിടെ തന്നെ അത് കൊറോഡ് ചെയ്ത് അങ്ങനെ നമുക്കിപ്പോൾ ഈ ഡ്രഗ് യൂസഫേജ് ഫിസ്റ്റുല വരെ ഉണ്ടായത് കണ്ടിട്ടുണ്ട്. അപ്പോൾ സോ ഇറ്റ് ഈസ് സംതിങ് വിച്ച് ഹാസ് ടു ബി റിമൂവ്ഡ് ആസ് എൻ എമർജൻസി. വേറെവർ ഇറ്റ് ഈസ് ലോഞ്ച്ഡ്, ഇറ്റ് ഹാസ് ടു ബി റിമൂവ്ഡ് ആസ് എൻ എമർജൻസി. പക്ഷെ സ്റ്റൊമക്കിൽ പോയി അതങ്ങ് മൂവ് ചെയ്തുകൊണ്ടിരുന്നാൽ പ്രോബ്ലം ഇല്ല, അതങ്ങ് പുറത്ത് പോയി പോകണം. പക്ഷേ മൾട്ടിപ്പിൾ ബട്ടൺ ബാറ്ററി ഇഞ്ചക്ഷൻ ആണെങ്കിൽ അത് റിമൂവ് ചെയ്തേ പറ്റുള്ളൂ, ബിക്കോസ് ദാറ്റ് വിൽ അഡിയർ ആൻഡ് ഇറ്റ് വിൽ നോട്ട് ബി റിമൂവ്ഡ് അറ്റ് ഓൾ. അല്ലാതെ ബാക്കി സ്റ്റൊമക്ക് അല്ലാതെ ബാക്കി എല്ലാം നമുക്ക് ഉടനെ റിമൂവ് ചെയ്യണം. ഈവൻ ഇഫ് ഇറ്റ് ഹാസ് റീച്ച് ദ സ്റ്റൊമക്ക്, ഇഫ് ഇറ്റ് ഇസ് നോട്ട് മൂവിങ്, ഇറ്റ് ഇസ് അഡിയറിങ്, ഇറ്റ് റിമൈനിങ് അറ്റ് ദ സെയിം ഇൻ ദ സെയിം സൈറ്റ്, ഇറ്റ് ഹാസ് ടു ബി റിമൂവ്.
Okay. Is skin contact significant in kerosene poisoning?
സ്കിൻ വഴി അബ്സോർബ് ചെയ്യത്തില്ല, പക്ഷെ ഫുൾ ഇങ്ങനെ കുടിച്ചുകൊണ്ട് വരും എന്നുള്ളതേ ഉള്ളൂ. സ്കിൻ വഴി അബ്സോർബ് ചെയ്യുന്ന ഇറ്റ്സ് ഓർഗനോഫോസ്ഫറസ്. ഓർഗനോഫോസ്ഫറസ് ഒക്കെ ആണെങ്കിൽ സ്കിൻ വഴി അബ്സോർബ് ചെയ്ത് പോകും.
അടുത്ത വീണ്ടും ഗ്യാസ്ട്രിക് ലാവേജ് 10 to 15 ml per kg for each time, or is it maximum dose?
നോ, ഇറ്റ് ഇസ് ഈച്ച് ടൈം. ഒരു അലിക്കോട്ട് എന്ന് പറയുന്നത് 10 to 15 ml per kg ആണ്. അത് കൊടുത്ത് വാഷ് ചെയ്ത് കഴിഞ്ഞിട്ട് ക്ലിയർ ആയില്ല എന്നുണ്ടെങ്കിൽ, സലൈൻ മാത്രമല്ല വരുന്നതെങ്കിൽ നമുക്ക് അതുപോലെ വീണ്ടും അടുത്തത് കൊടുക്കാം.
How much time can we wait for button battery to pass?
അത് നമുക്ക് പേഷ്യന്റ് അനുസരിച്ചിരിക്കും. ഇഫ് ദ ബട്ടൺ ബാറ്ററി ഈസ് മൂവിങ്, you may wait. If the button battery is in the esophagus, it has to be removed. അവിടെ എവിടെയാണെങ്കിലും സ്റ്റൊമക്കിലും അടുത്ത ദിവസം തന്നെ അടുത്ത എക്സ്റേയിൽ തന്നെ അത് ഡ്യൂഡിനെ അങ്ങനെ പാസ് ചെയ്ത് പോയെന്നുണ്ടെങ്കിൽ വെയിറ്റ് ചെയ്യാറുണ്ട്. ഇല്ലെന്നുണ്ടെങ്കിൽ ഒരു സ്ഥലത്ത് സ്റ്റേഷനറി ആയിട്ട് 2 എക്സ്റേ കണ്ടാൽ ഉടനെ തന്നെ റിമൂവ് ചെയ്യണം.
ലെസ് ദാൻ 5 years ഒക്കെ ആണെങ്കിൽ അത് റിസ്ക് അങ്ങനെ
എന്തോ
ലെസ് ദാൻ 5 years ഏജ് വെച്ചിട്ടും യൂഷ്വലി റിസ്ക് കൂടുതലല്ലേ യങ്ങർ ഏജസിൽ?
അതെ അതെ, യങ്ങർ ഏജിലാണ് കൂടുതൽ ബെറ്റർ ബെറ്റർ റീറ്റെയിൻ ചെയ്യാനുള്ള റിസ്ക് ഉള്ളത്. ആൻഡ് അവർ ഇൻജസ്റ്റ് ചെയ്യുന്ന ഏജും അത് തന്നെയാണ്.
വേറെ ക്വസ്റ്റ്യൻസ് ഒന്നും ഇല്ല. എനിക്ക് തോന്നുന്നു മാഡം എല്ലാം അത്യാവശ്യം പ്രധാനപ്പെട്ട പോയിന്റ്സിനെ പറ്റി പറഞ്ഞു. നമ്മളെപ്പോഴും ഇതിനകത്തെല്ലാം ഒരു ഹൈലൈറ്റ് ചെയ്ത് പറയേണ്ടി വരണം. എനിക്ക് തോന്നുന്നത് പാരസെറ്റമോൾ പോയ്സണിങ് ആണ് നമ്മളിപ്പോൾ കൂടുതലായിട്ട് പലപ്പോഴും കാണുന്നത്. ഈ ഇത്രയും പല പോയ്സണിങ് ഒക്കെ ഉണ്ടെങ്കിലും നമുക്ക് മോർബിഡിറ്റി മോർട്ടാലിറ്റി ഒക്കെ കൂടുതലുള്ളത് പാരസെറ്റമോൾ പോയ്സണിങ് ആണ്. അപ്പോൾ അത് നമ്മൾ നേരത്തെ ഐഡന്റിഫൈ ചെയ്യേണ്ടതുണ്ട്. അതൊരു എഫക്റ്റീവ് ആന്റിഡോട്ടും അവൈലബിൾ ആണ്. അപ്പോൾ അതിനെപ്പറ്റി മാഡം ഒന്നുകൂടെ ഒന്ന് പറഞ്ഞിട്ട് നമുക്ക് നിർത്താൻ തോന്നുന്നു.
പാരസെറ്റമോൾ പോയിസണിങ് ഞാൻ പറഞ്ഞു കുറച്ച്. അത് നമുക്ക്
അതെ അതെ, പറഞ്ഞു
ഒരു
പറഞ്ഞു.
ഒരു കുപ്പിയോളം കുടിക്കുന്ന കുട്ടികൾ വരാറുണ്ട്. പക്ഷെ അതിനെക്കാളും കൂടുതൽ അത് നമുക്കിപ്പോൾ ആക്സിഡന്റൽ ആയിട്ട് ഒരു ബോട്ടിൽ പാരസെറ്റമോൾ കുടിച്ചു എന്ന് പറഞ്ഞ് വന്നാൽ അവിടെ നമുക്ക് സ്റ്റൊമക്ക് വാഷിനും ഒക്കെ റോളുണ്ട്. സ്റ്റൊമക്ക് വാഷ് ചെയ്ത് നമുക്ക് MT ചെയ്യാം. പിന്നെ നമുക്ക് മോണിറ്റർ ചെയ്ത് നോക്കിയാൽ മതിയായിരിക്കും. പക്ഷെ അതല്ലാതെ മിക്കവാറും ഇപ്പം നമ്മൾ കാണുന്ന കൂടുതൽ പാരസെറ്റമോൾ പോയിസണിങ്ങും ഇങ്ങനെ ഓവർ ഡോസ് കൊടുക്കുന്നതാണ്. പേരൻസ് 125 ml പകരം 500 ml സിറപ്പ് വാങ്ങിച്ചു കൊടുക്കുന്നത്, അങ്ങനെ വലിയ കുട്ടിക്ക് പ്രിസ്ക്രൈബ് ചെയ്ത് മാറിക്കൊടുക്കുന്നത്, ഡ്രോപ്സ് സിറപ്പിന്റെ ഡോസ് കൊടുക്കുന്നത്, അങ്ങനെ പല രീതിയിലുള്ളത് കാണാറുണ്ട്. അപ്പൊ ഇതിനകത്തെല്ലാം തന്നെ നമുക്ക് അറിയേണ്ടത് ഇത് ഒരു സിംഗിൾ ഡോസ് മാത്രമല്ല. ചെറിയ ഡോസ്, ചെറിയെന്ന് വെച്ചാൽ ഇച്ചിരി ഹയർ ഡോസ് ഓവർ എ ലോങ് പീരീഡ് ഓഫ് ടൈം, നമ്മൾ പറഞ്ഞ പോലെ 100 mg/kg പെർ ഡേ വീതം 3 ദിവസം കഴിച്ച് ദാറ്റ് ഈസ് ടോക്സിക്. അപ്പൊ ആ ഒരു കൺസെപ്റ്റ് എപ്പോഴും നമുക്ക് വേണം. അങ്ങനെ കഴിക്കുന്ന കുട്ടിക്ക് നമുക്ക് സ്റ്റൊമക് വാഷിന് വലിയ റോൾ ഇല്ല. ദർ യു ഡയറക്ട്ലി ഗോ ഫോർ NSAID-16 അങ്ങ് തുടങ്ങുന്നതാണ് നല്ലത്. ദെൻ യു കീപ് ദ പേഷ്യൻ അണ്ടർ ഫോളോ അപ്പ്. ലുക്ക് അറ്റ് ദി SGOT-PT. SGOT-PT വളരെ കൂടുതലായിരിക്കും. SGPT ഒക്കെ നമ്മളിപ്പോൾ 5000, 6000, ഈവൻ 10,000 റേഞ്ച് വരെയൊക്കെ SGPT കൂടാം. And prothrombin time is something that we use for monitoring of the patient's condition. If the prothrombin time is keeping on increasing, you know that the patient has not responded to our treatment and patient has gone into the acute liver failure. നാക്ക് കൊടുക്കുന്നത് ആക്ച്വലി അക്യൂട്ട് ലിവർ ഫെയിലിയർ കുറയാൻ വേണ്ടിയിട്ടാണ്, ഇഞ്ചുറി പ്രോഗ്രസ് ചെയ്യാതിരിക്കാൻ വേണ്ടിയിട്ടാണ് നാക്ക് കൊടുക്കുന്നത്. എന്നിട്ടും പറ്റുന്നില്ല, പേഷ്യന്റ് ഇംപ്രൂവ് ചെയ്യുന്നില്ല എന്നുണ്ടെങ്കിൽ ദെൻ ഇഫ് INR is very high, more than 7 ഒക്കെയാണ്, നമുക്കൊരു കിങ്സ് കോളേജ് ക്രൈറ്റീരിയ എന്ന് പറഞ്ഞൊരു സാധനമുണ്ട്. വി അസസ് ദി എലിജിബിലിറ്റി ഫോർ ലിവർ ട്രാൻസ്പ്ലാന്റേഷൻ. അങ്ങനെയാണെങ്കിൽ ലിവർ ട്രാൻസ്പ്ലാന്റേഷന്റെ ക്രൈറ്റീരിയ ഒക്കെ മീറ്റ് ചെയ്യുന്നെങ്കിൽ ഡെഫിനറ്റ്ലി ഇപ്പം നമുക്ക് ലിവർ ട്രാൻസ്പ്ലാന്റേഷന് വിടണം. വിടാതിരുന്നാലും നമുക്കതൊരു മെഡിക്കൽ ലീഗൽ റെസ്പോൺസിബിലിറ്റി ഉള്ളതാണ്. ബിക്കോസ് നവഡേയ്സ് ഈവൻ ഇഫ് ദ പേരൻസ് ഡോണ്ട് ഹാവ് മണി, ദ ഗവൺമെന്റ് മേ സപ്പോർട്ട് ആൻഡ് ഓൾ. അപ്പം അതുകൊണ്ട് ക്രൈറ്റീരിയ മീറ്റ് ചെയ്യുന്നെങ്കിൽ ലിവർ ട്രാൻസ്പ്ലാന്റേഷന് വിടുക. ഇല്ലാന്നുണ്ടെങ്കിൽ നാക്ക് കൊടുത്താൽ തന്നെ മതി. പേഷ്യൻസ് യൂഷ്വലി മെജോറിറ്റി ഓഫ് ദം വിൽ ഇംപ്രൂവ് വിത്ത് നാക്ക്.
നമ്മൾ കൂടുതലും കാണുന്ന ഈ സിറപ്പിന് പകരം ഡ്രോപ്സ് പുറത്തോലേക്ക്
ആ,
കൊടുക്കുന്നതാണ് കാണുന്നത്.
അത്
അത് നമുക്ക്
വളരെ
ഇതിനകത്ത്
കോമൺ ആണ്.
പെരിഫറിയിൽ ഇത് ഐഡന്റിഫൈ ചെയ്താലും ഇത് ടോക്സിക് ഡോസ് ആണെന്ന് നമുക്ക് മനസ്സിലായാൽ നമുക്ക് ഈ ഓറൽ NSC സ്റ്റാർട്ട് ചെയ്യാവുന്നുള്ള ഒരു കാര്യമാണെന്ന് തോന്നുന്നു നമ്മൾ ഹൈലൈറ്റ് ചെയ്യാൻ.
ഓറൽ നാക്ക് തുടങ്ങണം.
ഉം. വേറെ ഇൻവെസ്റ്റിഗേഷൻ ഇല്ലെങ്കിലും നമുക്ക് ഈ ടോക്സിക് ഡോസ് ആണെന്ന് നമുക്ക് ഉറപ്പാണെങ്കിൽ ഐ തിങ്ക് വി ക്യാൻ സ്റ്റാർട്ട്. അങ്ങനെയല്ലേ മാഡം?
അതെ അതെ. നമുക്ക് വേറെ ഒന്നും വേണ്ട. പാരസെറ്റമോൾ ലെവൽ നോക്കാനോ അങ്ങനെയുള്ളതൊന്നും വേണ്ട. ജസ്റ്റ് നാക്ക് തുടങ്ങാം. നാക്ക് ഇസ് എ സേഫ് ഡ്രഗ് ആൻഡ് ദാറ്റ് ഇസ് ദ ആന്റിഡോട്ട് ഫോർ പാരസെറ്റമോൾ. അപ്പം അത് നമുക്ക് അവൈലബിൾ ആണ്. നാക്ക് അങ്ങ് തുടങ്ങാവുന്നതേ ഉള്ളൂ. ഓറലായിട്ട് എവിടെ വേണോ നമുക്ക് തുടങ്ങാം. ഓറലിന്റെ ഉള്ളൊരു ഇഷ്യൂ എന്ന് വെച്ചാൽ it has a very foul smell and taste. So children may refuse to take that. We can put in an NG tube and give, or you can നമ്മൾ പണ്ട് കൊടുത്തിരുന്നത് ഈ ഫ്രൂട്ടിയൊക്കെ വാങ്ങിച്ച് അതിനകത്ത് മിക്സ് ചെയ്ത് കൊടുക്കുമായിരുന്നു. നവഡേയ്സ് ഇൻ SAT വി പ്രിഫർ ടു ഗോ ഫോർ IV എല്ലാം അവൈലബിൾ ആണല്ലോ. അപ്പം പിന്നെ പെട്ടെന്ന് എന്തായാലും വി വിൽ എൻഷുർ ദാറ്റ് ദ പേഷ്യന്റ് ഹാസ് ടേക്കൺ ദാറ്റ്. Otherwise, we can put in an NG tube and make sure that the patient has taken all the 18 doses. നമ്മൾ ആദ്യത്തെ ഹയർ ഡോസും പിന്നെ 17 ഡോസ് കൂടെ കൊടുക്കണം 4 hourly. അത് ഇത്രയും കൊടുത്തു കഴിഞ്ഞാൽ ദാറ്റ് വിൽ ബി സഫിഷ്യന്റ് ഫോർ മോസ്റ്റ് ഓഫ് ദ പേഷ്യൻസ്.
ഒരു ക്വസ്റ്റ്യൻ കൂടെ എടുത്തിട്ട് നിർത്താം. വാട്ട് ആർ ദ സാമ്പിൾസ് നീഡ് ടു പ്രിസർവ് ഇൻ എ സസ്പെക്റ്റഡ് റാപ്പിഡ്ലി ഡിറ്റീരിയറേറ്റഡ് അൺനോൺ പോയ്സണിങ് ഇൻ ചൈൽഡ്?
അത് നമുക്ക് കുറച്ചൊരു ഇഷ്യൂസ് ഉള്ളത്, നമുക്ക് മെഡിക്കോ ലീഗൽ സപ്പോർട്ട്, അതായത് നമുക്കിവിടെ ടോക്സിക്കോളജി സെല്ലും അങ്ങനെയുള്ള കാര്യങ്ങൾ നമുക്ക് ഇച്ചിരി ഒരു സപ്പോർട്ട് കുറവാണ്. നമുക്ക് പ്രവീൺ അറിയാമോ സ്റ്റേറ്റ് ടോക്സിക്കോളജി സെല്ലിനെ പറ്റിയോ മറ്റോ?
ഇല്ല വേണം, ഇല്ല അറിയില്ല.
അപ്പൊ ഞങ്ങൾക്ക് ഇവിടെ ചെയ്യാൻ പറ്റുന്നതാണെങ്കിൽ നമുക്ക് യൂറിൻ ആൻഡ് സിറം, അത് യൂറിനും സിറവും നമുക്ക് എടുത്ത് പ്രിസർവ് ചെയ്ത് വെക്കാം. പക്ഷെ ഏത് പോയിസണിങ്ങും, ഈവൻ ഇഫ് ഇറ്റ് ഇസ് എൻ ആക്സിഡന്റൽ പോയിസണിങ്, ഇറ്റ് ഹാസ് ടു ബി റിപ്പോർട്ടഡ് ആസ് എൻ എമർജൻസി. കാരണം പലതും നമ്മൾ ആക്സിഡന്റ് എന്ന് വിചാരിച്ചിരിക്കുന്നത് പിന്നെ ആക്സിഡന്റ് അല്ലാതെ മാറാം. അപ്പൊ എപ്പോഴും ഔർ സൈഡ് ഓൾസോ ഹാസ് ടു ബി സേഫ്, ഇല്ലേ? അതുകൊണ്ട് എല്ലാ പോയിസണിങ്ങും ഇറ്റ് ഇസ് ബെറ്റർ ടു റിപ്പോർട്ട് ആസ് എൻ എമർജൻസി. എമർജൻസി റിപ്പോർട്ട് ചെയ്ത് കഴിഞ്ഞാൽ ഈവൻ ഇഫ് സംതിങ് ബാഡ് ഹാപ്പൻസ് ടു ദാറ്റ് പേഷ്യൻറ്റ്, വി ഹാവ് റിപ്പോർട്ടഡ്, ഇല്ലേ? അപ്പൊ അതിനനുസരിച്ച് നമുക്ക് ഫോറൻസിക്കിന്റെ ഒക്കെ ഒപ്പീനിയൻ അനുസരിച്ച് ചെയ്യാം. സാമ്പിൾ ടു ബി ടേക്കൺ എന്ന് പറഞ്ഞാൽ സാധാരണ അക്യൂട്ട് പോയിസണിങ് ആണെങ്കിൽ യു ഹാവ് ടു ടേക്ക് ബ്ലഡ്, യൂറിൻ പോയിസണിങ്, ബ്ലഡ് ആൻഡ് യൂറിൻ. പിന്നെ ഉള്ളത് ചില പോയിസൺസ് ലൈക്ക് ലെഡ് ആൻഡ് ടൂൾ മേ റിമൈൻ ഇൻ യുവർ നെയിൽ, പിന്നെ ഹെയർ, അങ്ങനെയുള്ള അതൊക്കെ ഈ ക്രോണിക് ആർസനിക് പോലുള്ള പോയിസണിങ്ങിൽ നമ്മൾ പിന്നെ പല ഇന്റൻഷണൽ പോയിസണിങ്ങിൽ കാണുന്ന സാധനങ്ങളിലെ അതൊക്കെ ക്രോണിക് പോയിസൺസ് ആണെങ്കിൽ ഇതിനകത്ത് ഇരിക്കും, ഹെയറിനകത്തും നെയിലിനകത്തും ഒക്കെ കാണാം. അപ്പൊ അതൊക്കെ തന്നെ നമുക്ക് സാമ്പിൾസ് പ്രിസർവ് ചെയ്യാം. ഇറ്റ് ഈസ് ഓൾവേസ് it's always good to get the opinion of our forensic colleagues in these cases.
Thank you, madam. Think we can wind up the session. So I invite Dr. Merin from the academic cell for the formal vote of thanks.
Good evening, everyone. വളരെ നല്ലൊരു ക്ലാസ് ആയിരുന്നു മാമിൻ്റെത്. കുറച്ചേ കേൾക്കാൻ പറ്റിയില്ല, ഇടയ്ക്കൊന്ന് മിസ്സായി പോയി. എങ്കിൽ തന്നെയും നമ്മൾ പെരിഫറയിലൊക്കെ ഇരിക്കുമ്പോൾ പലതരത്തിലുള്ള കുട്ടികൾ തന്നെയാണ് എനിക്കും വന്നിട്ടുണ്ടായിരുന്നു. കുറച്ച് കുട്ടികൾ ഈ ഇടയ്ക്ക് ഈ റിസൾട്ടുകൾ വരുന്ന സമയത്ത് ആണ് ഏറ്റവും കൂടുതലായിട്ട് ഒരു 15 വയസ്സ് 18 വയസ്സൊക്കെ 15 വയസ്സ് 16 വയസ്സൊക്കെയുള്ള 10ാം ക്ലാസ്സിലുള്ള കുട്ടികൾ കഴിഞ്ഞ പ്രാവശ്യം കഴിച്ചിട്ട് വന്നിട്ടുണ്ടായിരുന്നത്. നമുക്ക് പെരിഫറയിൽ പ്രത്യേകിച്ച് ഒന്നും ചെയ്യാനില്ലെങ്കിൽ പോലും കാര്യങ്ങൾ അറിഞ്ഞിരിക്കുന്ന വളരെയധികം നല്ല കാര്യമാണ്. ആൻഡ് താങ്ക് യു. ഒത്തിരി പേര് സാധാരണ ഉള്ളതിനേക്കാൾ കുറച്ചും കൂടെ കൂടുതൽ ആൾക്കാർ ഇപ്രാവശ്യം ക്ലാസ് കേൾക്കാനുണ്ടായിരുന്നു. മാമിന്റെ ക്ലാസ് വളരെ ഇൻട്രസ്റ്റിംഗ് ആയിരുന്നു. എല്ലാവർക്കും നന്ദി. KGMO അക്കാദമിക് സെല്ലിന്റെ പേരിലും KGMOയുടെ പേരിലും മാമിന് വളരെയധികം നന്ദി പറയുകയാണ്. കൂടാതെ നിങ്ങൾ ഓരോരുത്തർക്കും നന്ദി പറഞ്ഞുകൊണ്ട് നിർത്തുന്നു. താങ്ക് യു ആൻഡ് ഗുഡ് നൈറ്റ്.
Thank you. And also I would like to thank Praveen and also the academic cell of KGMOA for having me. Thank you.
Thank you, Bindusha madam. Thank you. Thank you all. Good night. Bye.
Okay, good night.